Bismillahirrahmanirrahim. So, Mr. Gerard, 47 years old male patient, complain of cough. His vitals, blood pressure was 141/93, pulse 88, respiratory rate 18, temperature 37.8, his saturation in room air 96. Proceed, doctor.
Hello there.
Hello.
My name is Dr. Ahmed, one of treating doctor in the clinic today. May I confirm that Mr. Gerard, 47 years?
Yes, I am.
Mr. Gerard, we are here today to discuss some issues related to your health, examine you, and address your concerns. Is it okay?
Okay.
Can you please tell me what you are suffering from?
For the last 2 months, I have been complaining of cough.
Did it start sudden or gradual?
It was gradual.
Is it first time or you have faced this problem before?
No, it was the first time.
Is it related to any specific time of the day?
No specific time.
Is it related to any specific time in the year or season per year?
No specific weather.
Is it related to, have you noticed that it's improved during holidays?
No.
What's your job?
I am working in paper factory, paper mills.
Okay. So, is it increasing now from start?
I feel it increasing, yes.
Have you noticed anything make it worse?
What you mean? Something make my cough worse?
When you ever that exposed to a specific type of perfumes, or when you want to cold weather or any dust?
No, I did not notice anything like this.
Have you noticed anything make it better?
No.
Is it related to any pain anywhere in your body?
No.
Is it dry or contain phlegm?
It's dry.
Okay. So, okay. Any cough no blood?
No.
Any stiffness in your nose?
No.
Any nasal blockage?
Never.
Have you noticed that your shape of your nose have been changed?
No.
Any wheezy chest or noisy chest, I mean?
No.
Okay. So, any chest pain?
No chest pain.
An awareness of your heartbeat?
No.
And lower limb swelling?
I didn't notice.
Any weight changes?
No. Weight changes, I feel that I lost about 5 kg in the last 2 months.
Is it intentional?
No.
Any lumps or bumps anywhere in your body?
No.
Any high body temperature?
No.
Any feeling tired?
I feel tired.
Okay. Have you ever contact with someone has a chest problem?
No.
Mr. Gerard, do you have any past medical illness should be aware of?
For me, I have no past medical history of note.
Any history of surgical operation?
No.
Can you please give me your medication list that you are taking?
I am taking only lisinopril for the last 3 months because of my BP is high.
What is the dose?
5 milligram.
Any recent changes?
No change.
Okay. So, are you known to be allergic to any medicine?
No.
Any family history of note?
Family history, my sister has systemic sclerosis. My elder brother has pulmonary fibrosis.
How they are doing now?
They are okay on medication.
Okay. So, any joint pain?
Yes, I have joint pain.
Where is the site exactly?
Most of my joints are aching.
Okay. Any skin changes?
Yes, I noticed some skin rash in my body appear.
Can I see the rash?
Yes, I will share screen for some minutes.
Okay. .
Okay, this is my rash, doctor. Do you see it?
Yes.
Okay.
Okay. So is this rash painful?
Yes, I feel it's painful.
Is it numpy?
No.
Is there on the other side?
No, only in my legs.
Okay. So and skin tightness?
No.
Well, any eye pain?
No, it never happened.
Any vision problem at all?
No.
Any headache?
No headache.
Any fits before?
No.
Any pins or needle sensation anywhere in your body?
No.
Any weakness, any part in your body?
No.
What about your water work? Have you noticed any increase in frequency?
No change in frequency or amount. No.
Any history of passing gravels?
Yes, I passed one time stone before 1 year.
Did you seek any medical advice?
No, because from that time I am okay.
Okay, so anyone comment that you become paler than before?
No.
Any change in the color of your eyes?
No.
Any difficulty of swallowing?
No.
Well, any heartburn sensation?
No.
Any tummy pain?
Sometimes I have tummy pain.
What is site exactly?
It's all my tummy sometimes.
Okay, what is the nature of this pain?
Dull aching pain.
Any change in your in your bowel habit?
I feel I'm not passing my bowel habit like before. Now it's about once every 3 days.
Okay, and weather preference?
No change.
Okay, any history of travel?
No.
Okay, Mr. Gerard, you told me that you are working as in paper or manufacture.
Yes.
Okay, do you smoke?
Yes, I'm smoking.
How many cigarettes for how long?
30 cigarettes for the last 15 years.
Mr. Gerard, smoking is bad for your health, especially in your condition, and advise you to stop smoking. And if you would like, I refer you to smoking cessation clinic.
Okay, I will think, doctor. Okay.
Do you drink alcohol?
I'm drinking about 12 units per week.
Okay. Do you drive?
No.
Okay. Can I examine you?
Yes, you can.
Okay. I will start with hands for any clubbing.
No clubbing.
Then I will examine for any flapping tremor.
No.
In the palm of the hand, any palmar erythema?
No.
Okay, then I will take permission for skin pinch if there is any pain, any skin tightness.
Okay, normal.
Okay, then I will go for okay. Then I would like to examine the lymph nodes, anterior superior, anterior cervical, posterior cervical, and supraclavicular lymph nodes and axillary.
Okay, all are normal.
Okay, so well, after that I will go for a chest examination.
Okay.
I will take permission for expose the full unwearing of clothes, and then I would like to do chest movement,
Okay, chest expansion normal.
percussion note,
It's almost normal.
auscultation, looking for a start with the back. If there
Okay,
is
auscultation, I will share the voice, but I wish you can hear. If not, I will
okay,
tell you. Okay.
okay.
Tell me. Did you hear it, doctor?
It's difficult for me. Just can you please just raise a little bit the voice?
This is the maximum. Okay, I will.
Okay.
Do it again.
Okay. Okay. So, if ask the patient to cough, does this sound change?
No change.
What is the site exactly?
It's in the upper zone bilaterally and a little bit in the middle.
Okay, about vocal resonance.
No change.
Okay, so then I would like to examine for anteriorly for palpable second heart sound.
No.
Okay, then any res GVP.
No res GVB.
Then I would like to know the site of the pain exactly for joint. Any deformity or any swollen joints?
No swollen joint, no deformity.
Okay, then okay, for the eye examination, I will bring the torch looking for any redness.
Okay, normal.
Okay, and no vision problem at all.
No.
Okay, then I will go for lower limbs. I would like to examine the rash. Is it like raised, raised or painful skin rash, right?
Yes, it's tender, raised, and purple in color, as you see, and it's not numby or oozing.
Okay, so I would like to examine the abdomen for tenderness, and I would like superficial palpation for any tenderness
No
or
tenderness.
superficial
No.
masses.
Okay, no tenderness, no rigidity or guarding.
Mm-hmm. Any
You could,
organomegaly.
yes, you could appreciate there is hepatomegaly 2 centimeter below the right costal margin and splenomegaly also 2 centimeter below the left costal margin.
Okay, so regarding the hepatomegaly, any abnormal texture like nodules or anything, or smooth?
No, smooth surface, not tender, and the dull
Okay,
ulceration.
okay. Then I would like to auscultation over the spleen and over the spleen, if there is any splenic rub.
No splenic rub, no bruit in the other side.
Okay, so still have a time.
Still 1.5 minutes exactly. Try not to ignore the concern. 4 mark.
Okay, okay. What's your concern, Mr. Gerard?
What do I have, doctor?
I highly appreciate your concern, Mr. Gerard, from what you said to me. And after I examine you, I'm concerned that I have a condition called sarcoidosis. It's a medical term for medical condition in which there is it is disturbance in your defense system. It is gotten confused instead of attacking your bugs. It affect attacking your own system, attacking your own body, and this leading to formation of substance called granuloma. So as one of the part of this condition, it causes scarring of the lung and giving explains the symptom that you have. Actually, it is a multiple. It is long-standing disease which affecting many parts in your body. What we need to do now is to do some blood tests and imaging to confirm our diagnosis and to exclude others. Then we will sit together to discuss proper plan of management, usually taken care by a group of specialists in form of case doctor and gut doctor, specialized nurse, physiotherapist, and skin doctor, and might need to take snip test to confirm our diagnosis. Meanwhile, Mr. Gerard, I highly advise you to stop smoking because it's even worsening your problem. Do you have another concern?
Is it curable, doctor?
I'm sorry to tell you that sarcoidosis, it is the condition that you have, it is not curable. However, we will provide you suitable medicine to prevent and can control the symptoms.
Okay. Thank you, doctor.
Thank you for talking to me, Mr. Gerard.
Okay, thank you. Well done, Miss Dr. Abdelmanem. Excellent. Small point I will comment at the end. Okay, let's start examiner questions. Summarize your case for me, please.
This is a 47 years old man presented with 6 month history of 2 month history of dry cough on background of hypertension on lisinopril 5 milligrams, no recent change in the no change in recent dose. This cough is dry cough, not related to specific time of the day or related to holidays. And apart from that, he has a history of passing troubles and constipation. On examination,
Most of finding.
okay. So in chest examination, there is a bilateral apical fine crepitation that does not change with coughing, and he has on abdominal examination he has hepatosplenomegaly, and okay. So and there is bilateral painful red raised skin rashes consistent with erythema nodosum. So my summary of my finding features suggestive of sarcoidosis. Sarcoidosis.
And what is the differential?
My first differential is sarcoidosis. My second differential regarding the case or the cough.
No, no, regarding your case, all. When you will
Okay.
do differential, you will do differential, either the disease itself or the symptom you collect. You will say, for example, sarcoidosis evidence by what you said. And for example,
Okay.
do differential and against that.
Okay. My second differential is tuberculosis, but against
Excellent.
that there is no any history of contact or fever.
Mm.
My third differential could be vasculitis, like eosinophilic with, I mean, Sherg-Strauss syndrome.
Mm. What else?
Um, Other differential,
Lung cancer could be.
lung cancer, yes, one of the possibility, yes.
Patient heavy smoker and there is
Weight loss.
weight loss and there is manifestation of hypercalcemia. Squamous cell
Yeah.
carcinoma will release parathyroid hormone releasing peptide will increase the calcium, give you the manifestation of hypercalcemia also. You can put at any, after that, you can put ACE inhibitor related cough or pulmonary fibrosis. Okay. But the first two or three is very important. Okay. So what is your investigation for this patient?
Okay. Apart from, would like to do a routine investigation, complete blood count, renal function test, and electrolytes, especially calcium. Would like to do liver function test and enzyme. I would like to do inflammatory markers.
Mm.
For confirmatory test, I will go with angiotensin converting enzyme level and
It will be
high.
okay. And
And then biopsy could be by lymph node biopsy or skin biopsy.
not lymph node.
Lung,
But tell
lung,
me,
I mean.
can you do any imaging before going to biopsy?
Yes, I would like to do a high resolution CT scan and pulmonary function test.
And simple test.
And
You start with
sorry,
simple imaging. You can do
chest
just
X-ray.
yes, chest X-ray. What you can you may find in chest X-ray.
Might find lymph, hilar lymphadenopathy or
Yes,
reticulonodular shadowing in the apical lobes.
yes. It depends on the staging of the patient. So bilateral hilar adenopathy. Okay, this is
Mm.
يعني common. So bilateral hilar adenopathy, differential TB and lymphoma for this bilateral hilar adenopathy and high resolution CT. And the biopsy from the lung, there will be non-caseating granuloma. Okay, so
Okay.
what is the treatment for sarcoidosis?
For sarcoidosis, firstly, education and the counsel of the patient about his disease. Then the treatment would be a multidisciplinary team, pulmonologist, and pulmonologist.
What is the pharmacological treatment? What is the
Sorry,
pharmacological treatment?
the
Pharmacological treatment.
mainstay the steroid.
Okay. Uh, is there any rule for any non-steroidal treatment?
Might give as a type a drug immunosuppressant like azathioprine.
Methotrexate is more beneficial, and the hydroxychloroquine and the chloroquine. Okay. Also, infliximab also can be given. Infliximab, especially if there is any system involvement or osseous involvement. Okay. Do you know what is this indication for this? Other than what I said, indication for non-steroid agent,
It's indication for steroid.
indication of steroid, and the indication of non-steroid agent.
The indication of steroid, eye involvement, heart involvement, and hypercalcemia, or lung. Heart involvement, sarcoidosis, heart manifestation of the sarcoidosis.
So, did you examine the heart or the
No.
pulse?
No.
So very important to examine the pulse and the heart in a case of sarcoidosis, because one of the complications of sarcoid, as a conduction defect like heart block, it can cause arrhythmia, it can cause heart failure. So it's very important. Pulse and the heart. This is very important. This is only 2 or 3 points only you missed. Okay, but excellent,
Okay.
all Dr. Abdulmanan.
Thank you so much.
So what is the indication of non-steroid agent?
If not responding to the initial treatment.
Yes, excellent. Patient preference, always put it patient preference, and if there is any side effect of the intolerable side effect of the steroid.
Okay.
So this patient, same patient, if he came to you with polyuria, what is the most common causes?
Could be cranial diabetic insipidus or nephrogenic diabetic insipidus.
Excellent. And what is the most common skin manifestation of sarcoidosis?
Erythema nodosum.
And what is the most specific skin manifestation of sarcoidosis?
Lupus vulgaris.
Lupus pernio.
Lupus perineo. Yes.
Excellent. Excellent. Okay, Dr. Abdulmanan, very well done. Okay, also you can give non-steroidal in simple analgesic for polyarthritis if the patient has. Okay.
Okay.
Just 1 or 2 comment I will add. In this case, you are completely excellent. Just only you missed to ask about shortness of breath in the this is very partner of cough, always cough, shortness of breath. Okay, and in examination, as we mentioned, you did not examine the pulse or the heart. Okay, this is only. Otherwise, all are okay. And also in hypercalcemia, you have to ask about all manifestation of hypercalcemia, like you ask about tummy pain, you ask about change in bowel habit, you ask about passing gravels, only moody changes, only missing, and the bone pain, only these are missing, on bone, not joint. Okay, with me, Dr. Abdullah?
Yes.
Okay. Any question you want to ask?
No, thank you. Everything's clear now.
Excellent, really, doctor.
Thank you so much.
Even if you will, in this case, you will not miss 1 maximum or 2 mark if he's aggressive examiner. Anyone want to ask any question regarding this case? If I ask you about staging, Dr. Abdulmanan, staging, X-ray finding in staging for staging of sarcoidosis, do you remember?
Okay, stage 1, stage 0 normal.
Yes.
Stage 1 bilateral higher lymphadenopathy. Stage 2 the focal but bilateral hyperlymphadenopathy and infiltrate.
Excellent.
Stage 3 diffuse infiltrates. Stage 4 fibrosis.
Okay, excellent. Fibrosis, right. Excellent. Super, Dr. Abdulmanan. Any question or go to the other? Okay, Dr. Samah there? There is short case. If anyone interested, Dr. Samah told me. but I don't know if she's here or no. Just it's 6 minutes. Just you imagine that you are in the room for examination, and it will be a quick discussion on it. Anyone interested to take it? شكرا دكتور عبد الوهاب. Anyone interested to take the quick?
Can I, sir?
Yes, okay. Okay. Patient complain of cough, chest case, okay? Examine his chest. I'll give you 1 minute or you'll start.
So what is the case?
Patient is 40 years old, complaining of cough. Examine his chest. Station 1, chest examination.
Okay, sir.
You will start immediately or you want 1 minute, as you like.
We can start.
Okay, Doctora, let's start. I will give you 6 minutes. I will remind you when there is 1 minute remaining.
Okay.
Okay, proceed.
Hello, my name is Dr. Sobia, and may I know your name, please?
My name is Ahmed.
Okay, Mr. Ahmed, I'm here to examine your chest, and I'll have a good look at you overall, and then I'll present the patient.
Okay, doctor.
Okay, so I'd like to first of all inspect from the foot end side.
Okay, by
I'll
inspection,
look around the patient if there is any.
I will
Yes,
tell you
on
what is it.
inspection, I am looking at whole of the patient and sorry.
I think there's some delay in the voice.
Hello, can you hear me?
For me, I hear you.
Can you hear me,
Yes,
sir?
yes, I hear you. Any?
Okay, so I would like to examine from the foot end side,
Okay.
and I will have a good look at the patient from top to toe, and I'll look around him. If there's any cannulation or any catheterization or any other paraphernalia like any nasal prongs or anything, any oxygen cylinder around him, any sputum mugs.
Yes, there is sputum put and a lot of tissues.
Lot of tissues.
Yes.
Okay, and then I'll come near the patient. Okay, I've also observed during this time, I would ask the patient to remove his shirt if he has it on,
Okay.
and I'd have a look at the chest from the foot end side, whether there's any deformity or any bulge or any depression
No,
on any
actually,
side, and it is moving with respiration properly.
there is no asymmetry.
Okay, and then I'll come near the patient and see at his hands for the nails clubbing, any cyanosis, any
There is clubbing.
pellar clubbing is there. Okay, and then I'd like to see if there are flapping tremors.
No.
Then the pulse, um, bec- as you know, it is bounding in carbon dioxide narcosis. If it is there, the pulse.
Normal. Normal.
And okay, and so also please comment the weight of the patient. Is it cachexia if present?
No, no, a little bit
Weight
underweight.
loss.
No, no, not cachectic, but a
Okay,
little bit underweight. Yes.
fine. And the patient is lying, right? Lying down,
Ah, yes, comfortable. Yes.
comfortably lying. Okay, fine.
Mm.
And then I'll look at the patient's face also, bursting of lips or anything like that.
No cyanosis, no jaundice, no pallor.
Okay, fine. Now I'd like to again examine the chest from the side, a thorough look at the chest, any scars, any
No scar, no deformity.
pigmentation. Okay. And no deformities are there. Fine. So now I'll do the palpation. First, I'll ask you
You want to palpate the apex?
I want to palpate the chest, but before that, I would like to ask if you have any pain.
No pain.
Okay, I'd lightly palpate your chest first, a light palpation to exclude any, what you call it, surgical emphysema or anything like that. And then I'd ask you that I'll be auscultating your, oh sorry, palpating your trachea. So
Okay,
I'll
it's
be your neck, your in the center of your neck. I'll be palpating. So if any pain or anything, you can tell me.
no pain and
So
trachea is tense.
okay, is it central?
Yes, central.
Fine. Now I'll look for the apex beat. Is it at the right space, like in the normal position?
No, it's in the left, in normal position in the left, mid clavicular line, fifth intercostal
Right.
space.
Okay. And now I'd like to look for the chest movements in the upper part and with the butterfly method, and in the lower part. Are my thumbs moving equally apart while
Yes,
respiration?
normal, yes.
Okay. And the expansion is normal.
Expansion normal, yes.
Okay, fine. So then I'd like to. I don't think I have a need to do the VF. It is obsolete now, or we have to do in the
TVF?
exam.
No, TVF, no.
Okay. Now I'll go proceed with the percussion from above the clavicle, over the clavicle, and then downwards up to the in the front up to the fourth intercostal space, and on lateral sides, four to six intercostal spaces.
Okay, there is dullness bilateral basally.
It is dull bilateral
Yes.
basally.
Mm.
Okay. And is it stony dull?
No, not stony dullness. There is dullness, not stony dullness.
Fine. Now I'd like to auscultate the chest.
Okay,
I'll ask the
auscultation.
patient to
There is coarse crepitation. Also
course
in
captations
bilateral. Yes, bilateral
bilaterally
basis.
basally.
Yes.
Okay. I'll go for the VR. Please say 111 each time I put my stat on your chest
Increase.
from above downwards.
Increase.
So what is VR like?
There is increase in VR.
VR is increased bilaterally at the
Mm.
bases. Okay. So now
Time, doctor.
should I go for whispering pectoralic or anything like that?
Time finish, but I will add 1 minute for you, okay?
Okay. Any pedal edema?
No.
Okay. And the heart sounds are normal?
Yes.
Okay. Right. And then I'll auscultate also from the back if I have time.
Okay. Same
So
finding
at
as
the
in front.
basis. Okay, fine. So okay, I'm done. Thank you very much.
Okay,
Read
thank
rep.
you. It's better
Yes,
to
you
start
can read
in
reps.
just start to it's better to start from the back just because time is limited. If you can manage
Okay.
from front, okay. And they try to be organized because you examine the trachea. I suppose that you make the patient to sit again, he will lie down. So after examining the patient while he's lying down, then the patient will sit. You will examine for the trachea and cricosternal notch and these things and his back and the lymph node. Or you will
Oh
from
yes,
the
yes,
beginning, or if you want from the beginning, he's sitting and you will do these things and start in the back. Then patient lie down and you start in the front. It's up to you, but you organize and arrange it. So,
yes.
what is the diagnosis and differential diagnosis? What
Okay,
is the positive
my
finding for this patient? Positive finding,
okay.
only positive finding.
So the positive findings in this gentleman is that He has decreased breath sounds. Sorry, he has a dull percussion note at the basis bilaterally, and with that he has also decreased breath sounds, but with increased VR. There was
Okay.
increased VR, right?
Yes. Okay.
And
And
there was clubbing.
so, what is the diagnosis and differential?
So my top differential is um, idiopathic pulmonary fibrosis.
I'll tell you why you did not know the diagnosis, because you did not ask me about the course, this crepitation, it changed with cuff or no,
Okay, fine.
right? You did not ask
Right.
this question.
Yes,
So if you ask
yes, I
the patient,
missed.
yes, you ask the patient if you hear auscultate crepitation, you'll ask him to cough, change or partial change or disappear in secretion. Okay, it will change
Okay,
in like bronchitis, not a change like in the heart failure and in the pulmonary fibrosis. Okay, so
right.
what other differential?
The
Pulmonary
others can
fibrosis,
be
by the way, pulmonary fibrosis, if you sit in the exam, it will not be wrong, but it will not be the diagnostics. It will be one of the differential. He will not object, but there is one diagnosis is more accurate.
okay, fine. So it could be if the crepitations changed with coughing.
Mm.
So tuberculosis.
No, tuberculosis, it will not come like this. Tuberculosis may lead to this. Okay,
Yeah,
I agree with
it's
you.
a Pisces. Yeah, a Pisces. It affects the Pisces mostly.
No. Common in exam, he will give you a case like this. If the patient is having clubbing and the patient has bilateral basal or any crepitation, not bilateral basal, crepitations course and the change with cough and the cough is productive, the first likely diagnosis is bronchiectasis.
Bronchiectasis. Yes,
Yeah.
bronchiectasis due to any cause. Okay.
Yes. What are the causes of bronchiectasis in general, not in
It,
this patient?
yes, like cystic fibrosis
Yes, one of the diagnoses.
and post TB fibrosis
Okay. A
and
lot.
any chronic infections can.
Yes, infection. Can you organize for congenital and acquired? It will be better. Congenital like cystic fibrosis, like what else? If you found the apex on the right side, what will be the diagnosis?
And, Cartagena syndrome.
Yes, this is one of the causes of
Yeah.
bronchiectasis and
Young
congenital
syndrome,
cause.
Cartagena syndrome. Yes.
Yes. So now you said to congenital cystic fibrosis and the Cartagena. If this patient has deficiency deficiency in his immunoglobulin, also he will have recurrent infection and bronchiectasis. So
A beta.
hypogamma,
Yes.
hypogamma,
Hypogamma.
yes. And acquired, as you said, TB infections, measles, viral infection, measles, TB as a bacterial, fungal as allergic bronchopulmonary aspergillosis, and immune overactivity like rheumatoid arthritis, IBD, immune underactivity like HIV, obstruction like from body or cancer. Just I try to make it simple to keep in mind, okay? And
Yes.
idiopathic, one of the causes also. If I told you what is the investigation you will do for this patient?
So first of all, I'd like to have a chest X-ray of this patient.
Do you know what is
I-
the finding you may find in the patient bronchiectasis in X-ray chest?
Um, the bronchiectasis can be seen like as cystic dilatations on the chest X-ray,
Yes,
and with
there
that,
is
I'll
name.
go for
There is name for this. There is name.
yeah tram track appearance,
Yes, tramline shadows. Yes,
your
okay. And
bud and tree appearance, tree
no,
in bud or bud and trees.
body tree. This is in TB. This is another thing. Tramline shadow, like
Tram line, yeah,
ring.
tram line,
It
yes.
will be ring shaped shadow due to dilatation of the bronchiole. Okay.
Yes, yes. And
I
I'll
will
also
mention the
have
rest of
the
it.
sputum examination for him, like sputum DR, uh, AFB and sputum for cytology. And actually, I also forgot to ask the age of this patient. What was the age?
I told you he's 40.
40. Okay, fine. So the sputum examination also
Okay.
for gram staining and all.
And what else other than gram staining?
Gene expert,
No, this is for TB.
AFP.
Okay. If you are
Okay.
searching for the cause, okay.
Okay, for fungal hyphae.
Also, this is one of the investigation, but one is very important because you suspect infection, so you want to give antibiotic. So what you will do for the sputum
Gram staining.
and culture and sensitivity also. Gram staining
Culture,
will give
yes,
you
yes. Culture
gram
sensitivity,
staining will
yes.
give you an idea about, for example, this is rounded shape like this cocci, maybe like streptococcus or staphylococcus, but you cannot guarantee if it's resistant or
Yes.
sensitive. So sputum culture and sensitivity because you will give
Culture and sensitivity.
yes,
Very
antibiotic.
important, yes.
So I'm asking a lot to cover all the topic. So don't be bothered by this a lot of questions. So what are the treatment you will give for this patient?
So treatment, if it is so, like, what is the diagnosis, by the way, in this patient?
Bronchiectasis now.
Yeah, okay. So bronchiectasis, and it is not tuberculous. If it is not tuberculous, then I'll give the broad spectrum antibiotics, especially with the pulmonary coverage, like fluoroquinolone.
What is the common
And
organism in the bronchiectasis? What are the common
bronchiectasis, common
organisms?
organism.
Mm.
Yeah, Streptococcus pneumoniae
Yes. What else?
and Pseudomonas, if there's a structural lung disease already.
Pseudomonas, one of the organisms, but not common. But it's one of the bad organism, one of the worst organism in bronchiectasis. Common organism, all same organism in the
And Moraxella catarrhalis.
yes, Streptococcus pneumonia, Staph aureus, Haemophilus influenza, and Moraxella.
Moraxella.
These are
Staph aureus.
most of them
Yes.
inhabitant in the upper chest and the center. And the worst is Pseudomonas and Burkholderia. These are the worst organisms. I will do recap for this at the end for this case. Okay, so you will give antibiotic and okay.
Nebulizations.
Yes, and because the patient has a lot of secretion, this you have to do a nebulized hypertonic saline. I'll give you last question. Do you know any indication for prophylaxis for this patient?
Like antibiotic prophylaxis.
Yes, you'll give antibiotic prophylaxis, but when you will give any patient with bronchiectasis, you give him antibiotic or there is some patient.
Okay, I don't exactly remember, but I think if the patient has comorbidities and
No, it's if there is a recurrent attack more than 3 per year. These are the indication. Okay, thank you, Doctora. Thank you very much, Doctor. Well done.
thank you so much.
Okay, I will do a quick recap. One asked about the positive finding. Positive finding for this patient was there is clubbing, there is dullness on percussion, and there is coarse crepitation change with cough. The diagnosis is bronchiectasis. The question asked about the causes, and we mentioned, okay. Regarding investigation, as we said, investigation you will organize to confirm diagnosis, investigation for complication, investigation for the cause. To confirm diagnosis and routine investigation, CBC, SAR, and these things. Chest X-ray, you will see trim line shadow. High resolution CT, there will be signet ring appearance. For complication, as we mentioned before, all chest cases will end in respiratory failure, so you will do ABG. You will do ECG echo because all chest cases will end in pulmonary hypertension, and core pulmonary. You have to do also sputum culture and sensitivity, okay, if there is any secondary infection, and you'll do pulmonary function test also. And for the cause, as we said, according to the cause, suspect hypogammaglobulinemia, you will do immunoglobulin A and G. Suspect HIV, you will do HIV. Suspect TB, you will do sputum acid fast bacilli, sputum culture, sputum PCR, and so on. And regarding treatment, as we mentioned before, you will organize non-pharma and pharma. All chest case, non-pharma is fixed. Non-pharma, patient education, patient counseling, stop smoking, vaccination, pulmonary rehab, and the most important here is chest physiotherapy or postural drainage. This is very important, and support, which is financial, occupation, and so on. Regarding pharmacological, antibiotic, according to cultural sensitivity, you will give bronchodilator, mucolytic, nebulized inhaled hypertonic, nebulized hypertonic saline, and so on. And the indication of prophylaxis, more than 3 attacks per year. What you will give azithromycin or inhaled tobramycin if he went deep with you. Okay, and at the end, surgery like lobectomy, pneumonectomy, and at the end will be lung transplantation. This is the case of bronchiectasis, and is very common case in the chest station 1. Any questions? Do you hear me well? Because
doctor, do you think I'm ready for exam?
when is your exam?
Well, it's not now, but I'll be applying in the upcoming diet.
Okay, if you'll apply in coming diet, for example, you'll apply 17 February, and it's supposed to be at least after 2 months, so very good. But you need only to, before the exam, we need to be practice. During exam, you want to be confident and calm. This is the most important advice. Practice well before the exam. I think you see Dr. Abdulmanim, how he's taking the approach for the long clinical consultation. The examiner is checking your approach, how you are asking in focused target question fluently. He's not hesitant. He knows what he's asking about. He's excluding some differential and he's focusing on some point. Okay, and very important to be calm in the exam, because if you have a lot of information, if you become nervous and afraid, you will not remember anything. And confident, because also if you are hesitant, he can understand this point. This is very important.
معلش يا دكتور طلعت، كنت عايز اسال حضرتك يعني every center is different in the cases يعني or
Try
the
to
cases
be,
are
doctor, make it English because a lot of non-Arabic.
yes I want to ask regarding these cases either long or short, different from each center like Egypt, Jordan, differ the cases, or it's the same case here, it will be there also?
Where is your exam, Dr. Abdulmanan?
No, I have not yet booked, but I just I'm asking يعني internationally all the centers the same cases, or it will be different from center to center?
Different from center to center, but nowadays they are trying to long clinical consultation to cover rheumatological, to cover infectious, to cover ER emergency, because all other branches are covered in the short station. So rheumatological, this is very like systemic sclerosis, rheumatoid arthritis, sarcoidosis. A lot of these cases, they are coming. Sometimes he brought sometimes acute pancreatitis, pulmonary embolism, these things also. You got my point?
Yes, thank you. So
but
it depends also on the luck.
Yes, it depends on the luck.
Yes.
Because in Egypt, in last diet in Egypt, they bring bilharziasis and the complicated liver sulfur like this. So it's hepatology. So you cannot guarantee what will come, but at least you have to cover, okay, this rheumatological branch in long clinical consultation, because it has a lot of what you see. The story of this long case is not about you reach the diagnosis. Mostly it's about the complication or association. They like this. That's why in this you are good in asking past medical history very early. Don't make it at the end after asking. Sometimes he brings to you patient already diagnosed and have 14 years he's rheumatoid arthritis and came to you now with pulmonary fibrosis due to methotrexate and due to the disease itself. You got my point? If you still
Yes.
ask and have joint pain and you still analyze and will take a long time to diagnose rheumatoid arthritis, which is already diagnosed and the patient already on medication. So if you ask it, do you have any past medical history? He will tell you, I have rheumatoid arthritis. Show me your medication list. You will find methotrexate. Now your is clear for you. You got my point? And they picked it early at the first 2 or 3 minutes. Some doctors, some approach, they want to start by past medical history. To يعني decide from the beginning he will continue to ask and proceed in a question, or he will do redirection for the focus on the complication of the already diagnosed disease.
Yes.
Okay. Anyone want to ask any question?
Which one book would you suggest to go through?
No, there is no guarantee for this. Before they are telling Ajman is good, Shakha is good, and these are good, and the Basmark was not good. So this depends on a lot of things after يعني Allah, the examiner himself. This is very important. What he will accept from you, if you omit a question, he will consider it unsatisfactory or borderline, or he will not look at it. And if your confidence and approach. So no one can guarantee what will happen in the center or exam.
Doctor,
Yes.
is this session recorded?
Yes, I did. Yes.
Okay, thank you.
Because many asked it and I will upload it. Okay.
والله ما اعرف ذاك السيستم ده فيه ايش.
Anyone want to ask any questions? Okay, thank you. So we will end today. Assalamu alaikum wa rahmatullah.
الله.